fire safety apparati. We got a little exposure to diesel fuel and some extinguisher output. It'll all be fine. We'll survive it. It's really good to actually demonstrate that, to try that, because as you can see, if you're in an actual emergency, it's nice if you've done it once or twice before, if you've actually used an extinguisher, and you can see, how effective it is on small fires, and when you are under a lot of pressure in an actual emergency, it's even harder to focus. So having that ability or having that knowledge of how the extinguisher actually works, I think is a good thing. I did it once last year for the first time and found it useful. We do want to remember that if there's a small fire, if we know where the extinguisher is, we should grab it and put the fire out, because if we put the fire out early, it will save what could be a very, serious tragedy. Because we saw in the film a couple of minutes and the whole place will be going up. So if we can get that fire out, that's a good thing. And also the bed sled, great tool, but a little bit complicated. If you had never seen it or done it, I don't know if I could actually use that effectively without actually having put my hands on it, see where the straps are, and see how you put the cover over the patient. God forbid we ever have to use that, but if we do, it could save a life. And the stair chair as well. If we get somebody in a wheelchair that we have to bring down the stairs, there's the emergency stairs at the end of long-term care. Charles probably told you about that, and that's where the stair chairs are on the hospital level and the residential level for long-term care. If we had to bring someone out that staircase, there could be a fire, say in the nurse's station, or smoke, and the smoke door is closed. We can't bring them out that way. We'd have to go down the stairs, and that's the way we get people that are limited ambulation out of the building. And it's a great tool because it's not that hard to use. It's got that braking in it, so you don't have to have the person's weight. You don't have to be, handling all the weight of the person you're bringing down, because the chair does it for you. So any comments or questions about what we did or saw? Comments? Think it was useful or?
Very.
Thought it was useful? Okay, good. Yeah, the last 2 days we did it with everyone as well. We've done it, this is the third day, and we've done it a little better each day, but this was the first day where the wind wasn't with us. The last 2 days, the wind went up and around the corner. Everyone was able to stand on the pavement very close to the demonstration and not get any blowback. Today, we had to keep moving around. Kind of reminded me of the old days when I was a Boy Scout, and we'd have to keep switching around the fire as we tried to keep ourselves warm or cooked around a fire, because the smoke was always shifting. And actually, when you're one of the initiations in the Boy Scouts, I remember it very clearly when you're only about 11 or 12. The older scouts, when you're out camping, they send you throughout the campgrounds looking for a smoke shifter. They say, see if you can go down to the next campsite and ask them if they got a smoke shifter, and for some reason it works every time. You really think there's a smoke shifter. It keeps the smoke going in one direction, but believe me, there's no smoke shifter. I asked a lot of people. I fell for it too. So, okay, let's get going with our next presentation. We're going to do a short presentation on compliance, corporate compliance and incident reporting from 11:15 to 11:45. It's about a half an hour. We do some we have a great presentation by Lois Denherder on back and body mechanics. And that's very interesting about some common things that we can do to keep ourselves safe from workplace injuries, which are more common than you think, and also make our physical environment a little bit better for our daily work. And then we're going to take our lunch break, I think, at 12:15. So, okay, are we up? Yeah, I will. Okay, so one of my roles in the hospital is Chief Compliance Officer. I am responsible to monitor the hospital's compliance with federal and state laws, regulations, and requirements for the healthcare industry. Far from perfect at that. There's so many laws. I mean, major hospitals have teams of compliance people. This is one of my many roles here. So we do what we can. We use the resources, like in every aspect of what we do. We make the best of our resources, and that's a good thing because we need to be here for the community. The community needs to have access to basic healthcare and hospital services and long-term care services. So we're the front line, and we're what they have. And it's better than if we weren't here, right? It's a lot better. So think about that. Think about a community without access to healthcare that's on an island. So we're here, and we're going to do the best we can with the resources we have. If we continue to work together and we engage each other, we can improve those resources. We can improve our strategies and our techniques and what we have available to us to help grow our services and protect our patients' health and safety. So, I don't know why is that out of focus, or is that me? Okay, so one of the main federal laws that we deal with is the Health Insurance Portability and Accountability Act that was passed in 1996. One of the little things embedded in that was patient privacy. There's no privacy in HIPAA, in the acronym HIPAA, but that's what it's come to be known for, is patient privacy. It's a segment of the Portability Act. And we think we know, and we never know fully the complexities of the law, how the law is going to be enforced, how the law is going to be interpreted by courts, but generally we all know that that patients who come to a healthcare institution have a right to privacy in their healthcare information and their interactions with their healthcare providers. And because we work here, we will have access to private information, and we need to understand and remind ourselves that it's all of our responsibility to protect that privacy of that patient. Not only because it's their legal right under HIPAA, but because we want to maintain the highest standard of quality here, and we want the public to have a high level of confidence that when they come here and they share private information, especially in a small community, it's not going to be discussed that night at someone's dinner table, or it's not going to be shared in a casual conversation in a community by a staff member here. So that, maintaining our customers' confidence in our institution is very important to us, of course, and we all understand that. So HIPAA sets the national standards for the protection of health information. PHI is Protected Health Information. That's another acronym that we'll talk about this morning. And the last point on that slide, which is I think the most important point, a patient's health information is on a need-to-know basis. So if we work here, it doesn't mean we have a right to that information because we can keep it private. No, it's only on a need-to-know. So if a doctor has to discuss a patient's care with a nurse, that shouldn't be shared with another staff member. If you're involved with direct care of a patient and you have information, you shouldn't be talking about that over lunch with another nurse or another doctor or another colleague. You shouldn't be sharing that and seeking some input, because that's actually sharing information that's on a need-to-know basis. It's only to be shared with those that are in the direct line of care, or if it's part of a billing process, or if it's part of the revenue process, or we have to provide information on a transfer. If we need to have the information, that's when we should have the information. Any questions on that point? Okay. So PHI, again, is protected health information. Patient's medical record number, information that's in the medical record, patient images. Anyone know what a patient image would be? An example of a patient image? What's that, Beth? Colonoscopy, right. There's images of colonoscopies. There's x-rays, there's EKGs, there's images that make up part of the patient record. Conversations regarding that's protected information. If you're a doctor talking to a nurse about making decisions about a patient's health care, that conversation is protected. So if you overhear those conversations, you're duty bound to keep that to yourself. Conversely, people that are talking about protected medical matters should use what they can to keep that private. Lower your voice. Step aside. Go into a room if possible. Only mention the information that's most important. Don't talk about the patient's name or other identifying factors. If you can avoid that in the conversation. Who needs to know about HIPAA? Everyone, of course. It's like so many other things we'll talk about today. Everyone has a responsibility to maintain patients' privacy. This is legally protected information. We are all legally bound. The hospital has a mandate to ensure that we as staff members are maintaining patient confidentiality. It's just like if you happen to be in the long-term care wing of the hospital and there's a fire, you don't step aside and wait for someone else to rescue someone. You've got to do that, or you've got to put out the fire with the extinguisher. Everyone is responsible. Everyone that works here. It's the same with patient privacy. Can I access my own information? No, you can't do that. You can't access your own information. The way I like to think of it is when I'm an employee, I'm an employee. When I'm a patient, I'm a patient. They don't mix. So if you're a patient here, which many of us seek healthcare treatment here. I mean, who would go elsewhere, right? I go here. I go to the clinic, and if I have access to Centreat, if I wanted to look up my own record, I couldn't do that. And the reason is we have to follow the process that's available to patients. So patients currently, they have to seek that data from the appropriate source, whether it's HIM or the lab or the clinic that's authorized to disclose that information with a release of information form, ROI. We've got to do that too. We've got to request that information. We've gotten into a little trouble in the past. Some people have, out of convenience, they wanted to look up their own information, their own lab results, or something on a family member, and that's not permitted. So keep that in mind as well. We are working towards a new EHR system, hospital-wide for the clinic, that will incorporate a patient portal. That's the future of healthcare. Patient healthcare communications. You'll be able to go into a secure, encrypted patient portal with certain identifying data and access your own patient record. So we're moving to that, but we're not there yet. Goes for a friend or family or a child. You're not entitled to do that. If a patient outside of the hospital can't look up information on Centreat, you shouldn't be doing that as well. HIPAA is everyone's responsibility. If you witness or see a violation of our HIPAA policies, it's your responsibility to report the event. You can report it to HIM or to compliance, that's me, at 301, or there's we actually have an anonymous tip line for compliance concerns, 333. And all complaints will be investigated and action will be taken if appropriate. I guess, we don't like to highlight disciplinary action, but I'll just go back to the thought that we as an organization have the responsibility to protect patients' information. So if we know there's someone in the organization that's not able to protect information, we have to be aware of that and try to deal with that in the appropriate way. It's our responsibility to ensure that the patient's information is protected, and we need to track it. The law requires us to become aware of these events, just like any safety event. If there's a disclosure inadvertent, it happens. It does happen here. It happens across the country. We might send a fax to the wrong place with patient information. We had an incident not that long ago where two patients had the exact same name, and we disclosed to the wife of patient 1 the patient information on patient 2 inadvertently when she was asking for some information that she was entitled to on her husband, but the other person that had the exact same name, we inadvertently gave that information. And HIPAA requires us to notify the patients that are affected. So if we don't find out about the disclosure, we can't follow the law that requires us to disclose it to the patient. Most patients are typically understanding. In fact, good luck with that. We do have, let's go back there. Any questions on HIPAA, concerns or input or experiences that anyone wants to share? Teresa, anything on HIPAA?
Very good.
Have any good cases?
Do I have good cases?
Yeah, good examples.
Well, I suppose there was an example not too long ago where somebody accessed or had information about a friend and asked them
Yes, that's a good point.
in the hallway how their ailment was doing.
Right, we had a staff member, a very well-meaning person who was concerned about a friend who was a patient here, and she asked the patient, how is your leg doing? Very well-meaning, but that staff member wouldn't have been in the course of that, the line of communication about the treatment. It wasn't a clinical professional, and they wouldn't have been she wouldn't have been normally had access to that information. She had access to it inadvertently, which is okay. But then where the chain broke was she had to keep that information to herself. And she asked her friend, how's your leg? And that was actually a disclosure of protected information. And so, we just had to remind that person that that was just another example. These things come up all the time. And you're like, yeah, I guess I shouldn't have said that. It's a difficult part of our job, not being able to go home and talk to our spouse or our significant other or friend or family member what went on today. We can't share examples of cases with people at home. We're just not entitled to do that. We are legally bound to keep that information to ourselves. So when you go home, just limit your talk. When you talk with your family member, your loved one, just complain about your supervisors or something other than that. Just limit it to that. Complain about your pay. Complain about your supervisors, your working conditions. Hopefully you won't have to do that every day, but we all do.
What about social media? Facebook,
Very good.
you see all kinds of stuff a lot of times there too. And
Social media, good
Yeah.
example. So what?
An example would be somebody posts a prenatal picture of their fetus. Maybe it's not their fate, maybe it's grandma, maybe it's some well-intended relative.
That's okay. If a patient puts a picture of puts the picture of their fetus on social media from an ultrasound, right? That's okay. They can do that, but we can't do that as a staff member. We certainly can't comment on that or engage in that conversation because we are part of the healthcare institution.
What about all the, you see a lot of times people posting, and you don't know where it's come from. It may have come from the patient, but so-and-so has been sick in the hospital, and we'd like everybody to, prayer for them, whatever. And it's just kind of nebulous, where is this coming from? Do I even want to respond to it?
It's better not to respond. It's better not to engage. If friends of yours or family or people are engaged in social media and they're talking about their physical or medical condition, it's best not to engage in that because there's going to be a question about what we know, what we have access to as a healthcare worker. Beth, did you have something?
I just wanted you to repeat the question that you did.
Yeah, okay. Anthony, you have another one?
You pretty much kind of said. Same thing like civilians and everything else. They can express as much as they want. They can say anything they want. They can take pictures. They can sit on a scene and film. But as healthcare profession, we physically can't say it.
Right, and Anthony, good example. Now he works at the fire department, right? So the EMTs bring someone here with a serious condition, and later that day, Anthony's down at the fire hall, and they say, "Oh, what happened to that guy? Did he survive?" Anthony's got the best thing to say is, "I can't discuss it. I can't talk about it because I work at the hospital. I'm not allowed to discuss it." That's what I say. I'm just not able to talk about that. And actually, that has a twofold impact in town, because one, it's you're doing the right thing, and two, it really raises your credibility and our credibility. Is if you say that once to somebody in the community, I can't discuss it because I work at the hospital. You can't imagine what a positive impact that has as it ripples through that person's social group, that you weren't able to speak about something in the hospital. That's really our job. That's one of the hard parts about our job. Also having to work on a day like today, that's also another hard part. It's such a beautiful day, but such is life. Okay, corporate code. We actually do have a corporate code of conduct. We don't hear about it much. These are kind of annual training things or routine training. All employees are required to abide by the corporate code of conduct, and it's in a policy. You may have noticed we have a few policies here, so in your spare time you can look up our compliance policies. There's a code of conduct. Sitka Community Hospital places the highest importance upon its reputation for honesty, integrity, and high ethical standards. This basically, most of this has to do with fraud. So CMS fraud, Medicaid fraud, Medicare fraud. We have to be very careful that we're not making improper claims, items for services. We can't make false claims. We can't submit claims by someone that's not a licensed physician or a caregiver. We can't make false statements to gain rights to benefits. We can't conspire to defraud. You know, we've never had, in recent history, we've never had any problem with this here, and we don't think we will. But these are some of the main laws. Again, we've got HIPAA, we've got Medicaid fraud. We've got to be very careful about our processes for billing, because if we bill something improperly or it's based on an improper data, it could be considered fraud. This last thing, patient dumping, refusing to provide appropriate medical screening exam to determine medical emergency, refusing to stabilize the condition, or refusing to transfer a patient for care. That's another sort of biggie federal act. Who knows what the acronym for that is? What's that? EMTALA, yes. You heard of EMTALA? We talk about that. A lot of people, it's kind of a nebulous thing, EMTALA. What does it stand for, Teresa?
Emergency Medical Treatment and Labor Act.
Emergency Medical Treatment and Labor Act has to do with deliveries, right? Labor. Emergency medical treatment. Basically what that means is, generally speaking, we can't refuse care to a patient at the emergency department, generally. So if someone is delivered here, comes in on an emergency, they're entitled to a screening, appropriate medical screening. So a doctor would screen the patient, and if the doctor determined that the patient needed stabilization and otherwise wouldn't be eligible for care here, we have to provide that care 24/7, emergency department. Doesn't mean we have to provide other medical services in the facility, but we do have to stabilize the patient. Any questions on EMTALA? We'll talk a little bit more about that as we go through. That's one of the biggies. HIPAA, EMTALA, and there's one more. Let's see. Anti-referral, presenting a claim for reimbursement to an individual, third-party payer, or other entity that were provided from a referral by a physician who has a financial relationship with a hospital, or also kickbacks. That's another act that has a pretty common name in the healthcare industry. You got HIPAA, EMTALA, Medicaid fraud, and begins with an S. Stark. The Stark Act. Anyone ever hear that? The Stark Act. That is not an acronym. That is the name of the congressman that introduced the act in Congress. And basically, it doesn't really apply to us in most cases. In some parts of the country, physicians might be investors or own an interest in a for-profit surgery center or other treatment facility, and there's a wall there. They can't refer people for treatment. They can't use their professional medical judgment to refer people for treatment to a facility that they have a financial interest in. It's not the same thing as being an employee. It's being invested in or being an owner. That doesn't happen here. We're owned by the city. But we could be in a situation of kickbacks if we paid doctors for referring, if we pay doctors a commission or something of that nature for referring patients for care. We can't do that. That's the anti-kickback part of Stark. Okay, a couple of the biggies. Let's see. Let me go back. Yes. Corporate compliance program. This is our program. We actually do have a program. As I said, it's limited based on our resources, but we have a compliance officer. We do not have an active compliance committee. We do need to work towards that. There is a code of conduct with written policies and procedures. We'll show you where to go for those at the end. There are guidelines on reporting to the compliance officer. Those that are in our compliance procedure. And we have an education program, as limited as it may be. And there are employee obligations, and those are: 1, you have a reporting obligation. Employees must immediately report to the compliance officer, that's me. I guess this is me down here. Any suspected or actual violations of applicable laws or regulations by the hospital or any of its employees. That's important. We talked about HIPAA, we talked about Stark, we talked about Medicaid fraud, we talked about EMTALA. I find a lot of times people are quick to judge that there's a violation. I hear people all the time say, that's an EMTALA violation. Well, I would just say, don't assume that we're violating the law. If you have an instinct or a concern, we have people to talk to. Talk to your supervisor or talk to me as the compliance officer. If you have a concern or if there's something telling you there's something that's not quite right with this situation, you should report that, and we will review it and we'll make a determination of how to handle it. Okay, I guess that's it for compliance, and we're going to just talk a little bit about incident reporting. Anything on compliance? Anybody want to talk about the Stark Act more? No? Okay, EMTALA. Any concerns, questions, examples of EMTALA that have come up that you know about? Oh yeah, I was saying yesterday, we have to treat a patient in the emergency room, no matter how hard that may be. We get a lot of repeat customers, right? We get people that we would like to say, please don't come back, or give us a week off, or things like that. But no matter how hard it is, we do have to see them. Brenda sees them a lot, right? She knows about those repeat customers. She can't discuss it. But we have to treat them, yes.
When you were talking about EMTALA, you kept saying generally. So what kind of exceptions are you thinking of that when you said general?
Well, the exception would be if their condition is not emergent. If after a medical screening, their condition is determined not to be emergent. So it's not a revolving door. The people can't choose to come here and be treated because they want to. There actually has to be an emergent condition for us to be required to treat them. Now, obviously, we are flexible about treating people, and we try to find strategies to help people, even people with chronic conditions that may be alcoholic conditions or maybe behavioral health, an underlying behavioral health issue. We continually try to find strategies to help people, but we do have to treat them if it's emergent, if it's determined that their condition is emergent. Okay. Does that help? Okay. Let's talk a little bit about occurrence reports. They are officially occurrence reports. Most people call them incident reports. They're mostly known as that. I still call them incident reports. I think that's a good term. This is the legal definition currently under our policy. A report must be completed whenever a situation arises which is inconsistent with the routine operation of the hospital or the routine care of patients. So something out of the ordinary, something that happened that shouldn't have happened or wasn't intended in the course of that action or that delivery of healthcare or anything else that we are doing in the hospital. If somebody gets injured, or if a medication was delivered inaccurately, or if an exam was done, or if a procedure was done on the wrong limb, or these are some sort of obvious examples. We've had physical therapy treatment provided on the wrong patient. We didn't identify the patient. We went into the hospital room and we gave that the wrong patient to therapy. Luckily, there was no harm done there, but those are kind of examples where things go amiss, or a doctor doesn't sign an order, or an order was delivered inaccurately. And so that's when we might have to file occurrence reports. These are done routinely. Most people are very good about following up on incident reports, and we've actually started to make some progress on follow-up with incident reports and improving our processes. I think we're headed in the right direction. We have a long way to go. We're working now on an electronic incident reporting process, which we're hoping to roll out in the next couple of months so that we don't have to use paper. Let me just show you what we have now. So, yeah, let's go right into the form. Most people have seen these forms, most people on the nursing floor for sure, and the lab and radiology, but others haven't seen them. So this is actually our occurrence report. If you are involved in an incident which is out of the ordinary, or which was a mistake that you made or someone else, you're asked to please fill out an incident report, or we call them officially they're occurrence reports. So you put the patient name here, go down. Here you might, we would ask you to identify where they were, inpatient, if it's a patient issue, inpatient, outpatient, ER patient, visitor, staff, other is long-term care there. That's important because we're obligated to report things in long-term care that we don't have to report the inpatient incidents. So we try to segregate them when we compile the data. Go down, please.
Oh.
It's okay. So here we can check off if it's a med error, a patient fall, or an injury. We put the date and time here. That's very important because when we review these, we need to go back and at the exact date and time and check the medical record and talk to others that were on staff at that time, or that were on shift, I should say. Okay, go down. This is an important part. Keep going. Okay, so there's a bunch of boxes here. If these apply, if it's a dietary, like if we gave the wrong tray to the wrong patient and they were on a special diet and they didn't get it, or vice versa, that could be an incident. If it's a visitor incident, a fall, or if the floor is wet, the floor is dry, there's a couple things to check off. Keep going down. And this patient visitor complaints, that goes on a patient complaint form and goes to the patient advocate, which is Patrick Williams currently, although that's going to evolve because Patrick's got some new roles going on. An employee injury, if it's an employee injury, you use an employee injury form. What's that form called? You know?
What's it called?
Yeah, I guess it's an employee injury form.
Yeah, I
But
can't
there's a
remember
separate
the name
form.
of it.
So
Yeah,
those are the
it's
two
a work comp-
exceptions,
it's a
really.
workman's comp form.
Patient complaint, I really don't like you guys. That goes on a patient complaint form. Employee injury, that goes on an employee injury form. And this is very important. Please sign this and date it so that we can come back and talk to you. We might have some questions on this. Okay, let's go to the next form. That's the incident form, the occurrence report, and then we're going to look at the investigation form. These are the two main forms. So when you complete the incident report, which you should complete it on your shift, the same shift, you give it to your supervisor. You can either give it to me, you put it in my mailbox in the warehouse over here, or you can give it to your supervisor. And the supervisor will then complete this form, which is the investigation form. The supervisor will talk about what he or she may have determined after she spoke to the staff member, the shift member, and then there may be some additional comments by the reporter of the incident that the person puts here. Okay? Is there any more on that? Keep going now. And there may be some recommendations. I guess that goes on the other side. No, keep going now. Yeah, there's some recommendations for process improvements, and then here are the recommendations here. The supervisor may put some recommendations. That goes over to me in risk management, and I could either order a more intense investigation if it's a serious patient injury or risk matter. We could send it to a peer review if it's a medical treatment issue, or we could do a root cause analysis in rare cases. And I won't get into all that today, but it's very important. This is an important process because we talk about it all the time. You all know that, but if we don't know what happened, we can't fix it. We can't improve it. And we're going to end up going backwards as a hospital. We want to move forwards. The more we know, the more we share, the more we engage each other with concerns, with incidents, with this reporting, the better we will be. Okay. My slideshow. Okay, and these are the references. If you go into the intranet, you'll see, you can go into compliance and you can find these forms, or if you go into safety, you can find these forms too. So this is just a little closing comment. Your blood sugar is high, the doctor says, but your salt, pepper, ketchup, mustard, and grated cheese levels are fine. So that's good news for the patient. Okay, questions? Compliance, Stark and Tala HIPAA, Medicaid fraud, and incident reporting and investigation forms. Any other questions, comments? Okay, I guess we're done with that. Thank you very much for your attention.